This is Senate Appropriations again, and we're taking up Bill S-37, which has been referred to us. We're not quite sure because the role of this committee is to look at any appropriation or spending in the bill. I would like to make it clear for anyone listening that the role of this committee is to really look at the spending. We do not take additional testimony. That's really the responsibility of the policy committee, in this case, health and welfare, and that we know that obviously there are provisions within the bill that there's a difference of opinion and strong opinions on either side. But this committee is not going to relitigate those policy decisions that are reflected in the bill as it has been referred to us. Our focus is really to run through the bill and just make a determination around any particular spending nexus that might be there, although there's certainly no explicit appropriation attached or included in the bill itself. So we have with us Jen Carvey, Legislative Counsel, who will give us a very quick run through of the bill, and then we can move it out of committee depending on what the spending issues might be.
Okay, great. Good afternoon, Jennifer Carvey, Legislative Counsel. So I will give you sort of a high-level overview of S-37, which is an act relating to access to legally protected healthcare activity and regulation of healthcare providers. The first section adds some definitions in Title I, so they would apply across the statutes. These are definitions of gender-affirming healthcare services, legally protected healthcare activity, which is a lot of the focus of this bill, and House Bill H-89, that's kind of a judiciary companion, and also definition of reproductive healthcare services. So that's section 1, and I'm happy to go into more detail, but otherwise I'll keep it very high level. Section 2 relates to medical malpractice, and it is prohibiting malpractice insurers from medical malpractice insurers from adjusting or otherwise changing a healthcare provider's risk classification or premium charges for the malpractice insurance because of that provider providing legally protected healthcare. And in general, when we're talking about legally protected healthcare here, we're talking about reproductive healthcare services, including abortion and gender affirming care. So that phrase comes up a lot in different ways throughout the bill to protect providers of those legally protected healthcare activities. Section 3 is insurance coverage, and this requires health insurance plans to provide coverage for gender affirming healthcare services that are medically necessary and clinically appropriate for an individual based on their diagnosis or health condition, and that are included in the state's essential health benefits benchmark plan. That's important because benefits that are not in our essential health benefits plan, the state is on the hook to pay for under the state defrayal provisions of the Affordable Care Act. But by tracking the, I think, fairly expensive benefits that are already in the benchmark plan, we keep it within what's already being covered, and there's not a state defrayal requirement. So this coverage requirement includes Medicaid. Medicaid is already providing these services, as are the benchmark plans. And so there is little to no, the only, I think, cost exposure on this one would be in the state employees health plan, but I believe that is already covering most or all of these services as well. So there was no fiscal note for this bill. And my understanding from Nolan is that the impact, if any, would be nominal.
So let me ask, these are already legally protected. Why is this bill needed?
They are not necessarily legally protected. In fact, they're being banned in a number of other states. So one of the things that is being, so this piece of it is specifically ensuring that our insurance plans and Medicaid will, in this case, really continue to be providing these services because not only are they already included, they'd be required to be included. And for a lot of the provisions on the healthcare providers, it's to try to protect the providers, especially in the event that people from other states come to Vermont seeking care they are not able to receive in the states they live in.
Okay, thank you. I think it's important to understand the genesis of the bill.
Section 4 is coverage for abortion and abortion-related services. It requires health insurance plans to provide coverage for abortion and abortion-related care. That's my understanding that all plans in the state already provide this coverage, as does Medicaid. The difference here is that this bill would prohibit cost sharing, so co-payment.
I thought Medicaid was under the Hyde Amendment.
It is, so we pay for it with state-only dollars.
I
Right, so
understand
it's,
that.
yes.
So, which is not Medicaid, it's general assistance.
It is run through our Medicaid program, but I think from a financial standpoint, you're right, it's not paid for with, we can't use our typical funding sources.
You cannot, no, it's not Medicaid reimbursable, but as a result of a court decision many
Yeah,
years
that's right.
ago.
Exactly.
Yeah.
As a result of specifically a Vermont case.
Yeah.
In addition to similar cases around the country. The state is required to provide those services, abortion services in Medicaid, and so since we cannot use federal dollars for it, we use state dollars for it.
The reason I'm asking is a plan amendment.
Yeah, so this section 5 requires the Agency of Human Services to seek a state plan amendment from the Centers for Medicare and Medicaid Services or federal authorities if needed to allow Vermont's Medicaid program to provide coverage consistent with this act. And the way it was presented by the Department of Vermont Health Access is they don't believe they will need a state plan amendment. It's why they asked for this language to be permissive. So it's if needed, shall seek if needed.
Okay, but
So this is really codifying existing practice.
But I guess what I'm trying to do is connect seeking an amendment for Medicaid to cover, and this is for the abortion.
Well, this would be for gender affirming care
as well.
right. So it's really to provide coverage consistent with this act. So that includes whatever we might need to be seeking federal approval to get coverage of. And the two types of services here are gender affirming healthcare services and abortion related services. And may also be, I don't know the specifics, but there are certain medically necessary abortions that I believe are eligible for coverage with
In order to save
federal
life,
funds in order to save the life of the mother.
or rape or incest.
Right. So,
That's not
right,
That's
and then,
why.
right, and I believe there may be other circumstances in which a pregnancy termination is not an elective abortion, but is a medical procedure in the event of pregnancy loss. And those kinds of services may fall outside of that Hyde Amendment, I hope.
And so I wondered if the reason the bill is here has anything to do with the cost sharing parts?
Yes, so I think specifically this one does. So thank you. That's the piece I want to come back to. On page 8 in cost sharing, this is specific to the abortion and abortion related services section. It prohibits the coverage under this section from being subject to any co-payment, deductible, co-insurance, or other cost sharing requirement or other charge, with two exceptions. One is to carve out the high deductible plans, because we are limited in what as a state we can require first dollar coverage of under a high deductible plan in order for the plan to continue to be eligible for a health savings account under federal law. And then there's also a carve out for coverage provided by Medicaid. There is not cost sharing for most Medicaid services. There are small co-pays for the prescription drugs. And Medicaid, that DVA came in and said it would be operationally very difficult for them to take a service out of their existing cost sharing structure because of their.
So what about ERISA plans?
We cannot regulate the self-funded so-called ERISA plans.
I assume that was the case.
Right, we are federally preempted from doing so. We can regulate governmental self-funded plans, so that's things like the state employees health plan and the teachers plans. So those are covered by these provisions, and I think it is the prohibition on cost sharing in the state employees plan specifically that may have, to the extent there is any fiscal impact, would have the fiscal impact.
Are there any other coverages where we don't allow co-payment or cost sharing?
Yes.
series of several.
Yeah, there are several. And you will notice under the gender affirming care, there is not that same prohibition on cost sharing. Instead, it prohibits a health insurance plan from imposing a greater cost sharing requirement for coverage of gender affirming services than applies to other conditions.
So what is the policy basis for saying this, it's going to be exempt from your copay requirement versus some other medical procedure?
Since the chair is here, I will let her
I mean,
speak.
and that's a natural question, you know, why. Historically, there's always been, even under Medicaid, there's been a higher match rate for certain services, and so.
Right, I mean, I believe, my understanding, and the chair can say more if she wishes, is that there was interest among the committee to reduce barriers to access to abortion services. And to the extent that cost sharing requirements would discourage anyone or present a barrier to someone accessing that healthcare service, they did not wish to impose that barrier.
Other questions?
Yeah, we also heard that there were a few people affected by providing the cost from our insurance companies.
Right, that many people would either fall into the high deductible plan that wouldn't be touched by this, or maybe on a plan that already does not have a cost sharing requirement. All right, section 7. Here, so section 5 was the if needed, the state plan amendment if needed. Sections 6 and 7 are really similar provisions in the Board of Medical Practice statutes and the Board of and the Office of Professional Regulation statutes that would prohibit them from taking disciplinary action against a healthcare provider, including an applicant healthcare provider, solely on the basis that that provider provides or assists in the provision of legally protected healthcare activity, or on the basis of criminal, civil, or disciplinary action against the provider by the licensing board of another state based solely on the provider providing or assisting in the provision of legally protected healthcare activity. So a lot of the bill, as I said, is looking at protecting healthcare providers from
In
multiple.
the context of this national examination of state responses.
Exactly. Section 8 relates to these limited services pregnancy centers and talks about, creates a new subchapter in Title 9 in Chapter 63, which is consumer protection around pregnancy services center fraud. And it starts out with some findings about these centers. Limited services pregnancy center is a pregnancy center that does not directly provide or provide referrals to clients for abortions or emergency contraception. So there's these legislative findings and then an intent statement saying it is the intent of the General Assembly to ensure that the public is provided with accurate factual information about the types of healthcare services that are available to pregnant individuals. And they should be able to receive clear, honest, and non-misleading information about their options or voluntary choices after considering all relevant information. So it has some definitions, and then it creates an unfair and deceptive act. It is an unfair and deceptive act in practice in commerce on page 15. For any limited services pregnancy center to disseminate or cause to be disseminated to the public any advertising about the services or proposed services performed at the center that is untrue or clearly designed to mislead the public about the nature of the services provided. It talks about the scope of the advertising language and specifies that advertising or providing services is an act in commerce. So that it falls under the Consumer Protection Act and gives the Attorney General's office the tools they need to enforce it. Section 9 directs the Agency of Human Services to include access to reproductive health care services and access to gender affirming health care services as indicators for equitable access to health care in its community profiles of health and well-being analysis, which is something that they are already required to and do. And similarly requires the Green Mountain Care Board to include those service needs in the health resource allocation plan analysis that they are required to do under law. Section 10 directs the Office of Professional Regulation in consultation with the Board of Medical Practice to report to the House Healthcare Committee and Senate Health and Welfare Committees in November with findings and recommendations for legislative action to address any concerns about the state's participation or contemplated participation in interstate licensing compacts as a result of the provisions of this act. These interstate licensure compacts really kind of tie licensure to laws in a number of states, and so there can be some potentially unintended consequences or implications for Vermont licensed providers based on their compliance or lack of compliance with laws and on this, what we consider legally or would consider legally protected healthcare activity in other states. And so we have them report back on that. Section 10A adds a new chapter in Title 26 relating to interstate compacts and healthcare provider compacts. And this section would direct Vermont's representatives or delegates for interstate compacts for healthcare providers to seek amendments or exceptions to compact language or rules so that Vermont would not be required to discipline a healthcare provider for providing reproductive or gender affirming healthcare services that would have been legal if they were provided in Vermont. So report back from the regulators on implications for licensure participation in the previous section, and then this section would be directing Vermont's representatives to try to advocate for inclusion of language that would not require Vermont to discipline providers.
That seems to be a very serious concern within the medical community.
Very.
Yeah, I think I know that there's a court case out of Texas, and 3 women could,
I was just talking about that.
bringing a lawsuit because they ended up getting services. And that one of them was a very serious health condition. And they went to Colorado.
Right, because the providers had concerns about providing services that may have been technically legal under their laws, but created the potential for significant liability.
And her life is threatened as well, in trouble, right?
Right.
Section 11 adds a definition of emergency contraception to the pharmacy statutes. And then in section, in the,
Can I point out a grammatical?
oh no,
Well, in section 11A, you use over the counter with the hyphens, but then prior, you don't use that.
so sometimes it's whether it's over the counter as a modifier, as an adjective before the word, as opposed to something that is sold over the counter.
In over the counter, I saw that there's only 2 places it's used in the bill, but I assume
Where
11A, it's used over the counter with the hyphens and other non-prescription drugs, what makes it clear that it's over the counter means non-prescription. But if you go up to the bottom of page 19, whether provided over the counter.
right, so whether provided over the counter is not a modifier, it's a I guess prepositional phrase, whereas it is a modifier when you use the bottom of page 20 because it modifies
Describing emergency contraception.
And then I guess.
So we are being grammatically
Okay, good.
appropriate.
Well, my
I
main,
learned this from the editors.
and I guess my main question was whether it's clear that it always means non-prescription, but I guess the way we have these sentences that would.
I believe so. Certainly we can look at revisions if needed.
It's a common term used.
Over the counter?
Yeah.
Yes.
Meaning non-prescription.
Meaning non-prescription. Yes, I believe it's.
I get my prescription drugs over the counter.
They're handed to you over the counter.
No.
They're only available to you from behind the counter. You cannot help yourself.
Oh, so it's the cash register counter? Is that what counter we're talking about?
It's whether you could take it off the shelf and buy
Take
it,
it to
or
the
whether
counter.
you need to have a prescription to get it.
Which would be,
And
That's
don't,
why it's over.
and we won't have a discussion of where you put your parentheses
Okay,
before,
We
after.
were not asking questions.
So.
Okay. Yeah.
Alright, so we have a definition of emergency contraception, and then at the top of page 12, this would add, I'm sorry, 20.
Yeah.
Up at page 20, my apologies.
So,
This would add to the list of medications that a pharmacist may prescribe in accordance with a protocol, valid state protocol approved by the Commissioner of Health. This would add emergency contraception. So there are actually two types of emergency contraception. One type is available over the counter, what you may have heard of referred to as Plan B, and there's other brand names as well. And then there's another type that is not available, that's prescription only. Ella is the brand name for the main one there. And so this would expand the access by making these available through a pharmacist prescribing in accordance with the protocol from the Commissioner of Health, as opposed to having it be only through a physician or other prescriber. And then section 11A has to do with emergency contraception and vending machines. So this would allow a retail or institutional drug outlet, which is basically a retail pharmacy or a pharmacy in an institution like a hospital, or a post-secondary school, as defined in and subject to the education statutes, may make over-the-counter emergency contraception and other non-prescription drugs or articles for the prevention of pregnancy or contraception available through a vending machine or similar device. And this allows the Board of Pharmacy to adopt rules to regulate the location, operation, utilization, and oversight of the vending machines and similar devices in a manner that balances consumer access with appropriate safeguards for theft prevention and safety. Pause in case you need the committee. Section 12 relates to higher education and healthcare services available there. So this would add a new chapter in Title 16 on access to reproductive and gender affirming healthcare services. And it talks about these in terms of readiness, meaning the institution's preparedness to provide gender affirming healthcare or reproductive healthcare services to students. So we have a definition of gender affirming healthcare readiness. Also on the next page, gender.
How many reports do you have in here at Center Lions to report back?
I
There's
don't have
another
to
one.
count them.
Huh?
I'll have to count them.
Yeah, another, each institution
Report.
shall report annually on or before.
Right, they are reporting to the health department, and the health department is compiling those into one report for you. So you only actually have to look at if you're interested.
That's in perpetuity.
Yes, it does not specifically notwithstand the expiration provision, so you would have opportunity to
5 years.
revisit in 5 years and see if it was something that you still wanted to require.
So it would end in 5 years if you don't withstand.
If you don't do something to extend it pursuant to TDSA section 20D, it would.
You got that, Andy?
Yeah.
Section and
I looked it
everything.
up.
Yeah.
All right, excellent.
Favorite part of this.
Yeah, let's see.
Yeah, well, we heard the bill.
So this
I just
relates.
read it last night. All these little details are things that I've forgotten.
This section specifically applies to the University of Vermont and the colleges in the Vermont State College system. So we're talking about the public colleges and universities. Talk about some of the other terms that are used in here. It gives definitions for those. And then it requires, in what is the new section 2502, requires each of those institutions to report to the Agency of Human Services annually by November 1st on the current status of its gender affirming healthcare and reproductive healthcare readiness, including whether they have an operational healthcare center on campus, whether they employ healthcare providers on campus, the types of gender affirming healthcare services and reproductive healthcare services that they offer to their students on campus, and the supports that they provide to those students. Their efforts to help students get services from licensed healthcare professionals by telehealth, the institution's proximity to a healthcare facility that provides services that are not available to students on campus, the referral information the institution provides about facilities that offer these services not available on campus, including information about the scope of the services that are available at each facility, and then whether there's public transportation between the institution and the closest facility, that provides these services and whether the institution provides transportation.
And did they testify that they do all this or can do all this?
So there's a difference. UVM, proximity to the medical center.
Right.
Has a lot of this already done. The NBU isn't as well prepared, so this will give them an opportunity to evaluate exactly what they do have and then be sensitive to what they might need to improve.
Is this going to add cost to them?
Well, they didn't say that it would.
They didn't say so. I actually think it's somewhat scaled back from the original
It's
proposal.
very much scaled back from the original proposal. So it's really about what the readiness plan, what you have, and then maybe the gaps. It doesn't say to fill the gaps.
All right, section 13 just gives the timing on the first reports. So the first ones from the institutions would be due to the Agency of Human Services by November 1st, and the agency would provide its first legislative report by the end of January of next year. The last substantive section is section 14. It's a prohibition on disclosure of protected health information. And this is kind of what I'm calling in my head, at least a HIPAA backstop. So there's a lot of information that covered entities cannot provide in the way of protected health information, but there are some permissive disclosures allowed in certain law enforcement and litigation contexts. And so this would say, even if HIPAA would allow it, the state is prohibiting that disclosure, so it would not, the information would not have to be disclosed. So on page 25, in the middle of the page, it says, in order to protect patients and providers who engage in legally protected healthcare activity, a covered entity or its business associate shall not disclose protected health information related to a legally protected healthcare activity for use in a civil or criminal action, a proceeding preliminary to a civil or criminal action, or a probate, legislative, or administrative proceeding, unless the disclosure meets one of the following conditions. If it's authorized by the patient or their legal representative, if it is specifically required, the disclosure is specifically required by federal law, Vermont law, or rules adopted by the Vermont Supreme Court. We know it's not laws of other states.
Is that parallel other language that already exists in statute?
Not specifically. Some of this was modeled on a Connecticut law on this topic, and the rest was worked out with stakeholders from the medical and legal community. The disclosure is ordered by a court of competent jurisdiction pursuant to, again, federal law, Vermont law. It's a term of art. Look, it's under jurisdiction there. It's a term of art in the legal context. It just means a court that has appropriate jurisdiction. Not meant to say pejorative term.
No way. That's
Or rules adopted by the Vermont Supreme Court. An order compelling disclosure under this subdivision must include the court's determination that good cause exists to require disclosure of that information. If the disclosure is being made to a person designated by the covered entity or business associate and will be used solely to defend them against a claim that has been made or there is a reasonable belief will be made against them in one of these contexts, or the disclosure is to Vermont's Board of Medical Practice or Office of Professional Regulation in connection with a bona fide investigation in Vermont of a licensed, certified, or registered healthcare provider. Then we get to the effective dates. So a number of the provisions take effect on passage, but the two provisions of most potential interest of this committee on the top of page 27, sections 3 and 4, the insurance coverage pieces, would take effect on January 1st of 2024 and apply to plans issued on and after that
So
date.
did this bill go to finance because of the insurance provisions? Well, normally they do.
Well, I think it's not an operation of, if it had fees in it, it would have to go there by rule, but this is not it doesn't automatically go there, so they would have to request it. So it could go there, but I mean, there's sort of some split jurisdiction between Senate Health and Welfare and Senate Finance, and some bills just go through one or the other. But
An
that's
overlap of membership. Okay. An overlap of membership.
not this
No,
year.
no, just the jurisdiction.
Oh, so they're coming to.
Yeah, we do a lot of it.
Right, Senator Owens is on a different committee now. The state plan amendment provision takes effect on January 1st. But the request would be for approval of Medicaid coverage, if needed, would be submitted earlier than that so that the coverage could begin on that date. And then other pieces as well, the emergency contraception, the clinical prescribing by pharmacists would take effect on or before September 1st of this year when the Commissioner of Health approves the state protocol for that prescribing.
So in terms of any impact on the spending, it would be related to the coverage for health for state employees.
That is my understanding from Nolan. I will look at Amber, but we've checked in with him a couple of times.
And this is to give them the same protections as other.
Yes, I mean, it would
individuals
be
that are covered by other insurance types.
right. It's really applying it to everyone, applying the same provisions to everyone in the state over whom you have regulatory authority, I mean, the coverage of all the people you have regulatory authority to cover.
All right. Questions, Jen? So it's the spending impact is, oh, Senator Starr, sorry, I didn't see you.
Wasn't sure.
Well, I was just wondering, I still didn't hear any direct appropriation in the bill.
There isn't one. There
So
isn't
what-
one.
I mean, I don't see why we even got the bill.
Well, our determination is because some of the provisions would apply to state employees under the insurance plan the state has, that there was kind of that collateral impact, but there's no appropriation in this bill other than what would flow to employees under the state benefit plan. You can have the mandates for ERISA plans, which are self-insured. And we're sort of self-insured, but the state can, we can regulate ourselves and the other plan. So it's only because of that connection back to, the coverage provided to employees of the state that there's a nexus here.
Right, and it really seems to be likely the lack of cost sharing for abortion services.
So there's no, to answer your question, you're right, there's no specific appropriation. It's just that whatever impact there might be as a result of the cost sharing language might have on the state plan. That seems to be the only connection to spending that this bill would have. And the other, as was stated, Medicaid is already covering the services. This is just to recognize that these are, they're controversial and there are people who feel very strongly on both sides. But this is a matter of saying that, that these are procedures that are standard medical practices, there are protocols that guide them. I imagine that I know for certainly for the late term, which are very, very rare, there are ethics committees that are in place and so forth. So these are procedures that providers, they're very well established protocols. It's just clearly identifying as a state, because the states are having to do more of this in light of court decisions, and there's been concern around the provider community, and then there's been concern about constraint on access. So I gather that that is the motivation of that changing landscape from state to state that this bill is being advanced. If that's a
Right,
good summary.
that's a good summary, and because it does provide protection for medical professionals in the state who are treating patients both in the state or perhaps their patients who are out of state. So it protects those professionals from,
And you said some of this bill is modeled after a bill passed in Connecticut?
Massachusetts.
Most of it is Massachusetts, some of that disclosure of protected health information is Connecticut.
Other questions or comments?
Are you looking for a motion?
I'm looking for a motion to move the bill.
We already got one.
Who's?
Senator Lyons.
Oh, Senator Lyons already moved. Oh,
Happy to second.
okay.
Okay.
And so, and any other questions? Like Senator Sears, you're back. This is, the financing implications here are really kind of secondary in terms of what copay impact has on the state employees covered by the state plan. But that's the, it's not, there's not an explicit appropriation here. It's just to put the protections in place for these healthcare services. So,
Burrows. Yes.
Yeah.
Lyons.
Yes,
Birchlight.
Yes.
I'm assuming Bob
Sears.
stuff. Senator Sears,
Yes,
Star.
No,
Westman, yes. Kitchell.
yes. And the reporter will be Senator Lyons.
okay.
Did you write down your Lyons?
And I think that takes care of today's, oh, wait a minute.
That was it. That's 37. Last on the chalkboard.
No, I guess we're done. We're done. I was looking, oh my gosh, we have corrections coming in. That's tomorrow. Okay, so tomorrow then we're back on the budget and we'll try to get through as much as we can on that.
do we have S4 on the agenda at all this week?
I wanted to.
It's not right now, but I can.
It's the.
It's,
the 10 million.
it's the Sears program to save the world.
Oh,
Yes.
let's do it.
We do need to put that
It did
on.
get sent to us, right?
Yes, we do have it. We'll take it up this week, Dick.
Thank you.
And then the only other bill we have in here is the DMV bill.
Yep.
And I don't know how much testimony you want to take. The only reason we have that bill in here is two reasons. One of which is the reimbursement to towing companies to tow abandoned vehicles hasn't been updated in years. I think it was $25. And there's no way.
I think it was 40.
Was it 40?
40.
Okay.
I just looked at it because there's some questions about that section.
You got it.
You want me to go offline?
No, it's just, they want to raise it to 125.
125, right. But that's a different issue of paying for legitimate as opposed to the other issues that are coming up where some companies in other areas have used. And then, so. So I guess we'll